next speaker, Dr. Raj Rai, I assumed that he knew nothing about AI, but last night we had a reception to kick off this conference, and I had a fascinating discussion with Dr. Rai, and it turns out he's kind of on the leading edge of using AI. But today he's going to talk about wound care, and thank you so much for being our guest speaker on wound care today.
Thank you, Singh. How fortunate for you all, you get to listen to wound care right before lunch, huh? No, I'll try to keep it fairly clean. So when I was asked to do this presentation, I thought about it, and I thought, well, what can I talk about in 25 minutes that would be high yield, that would benefit everybody, and what can I narrow it down to? And so I started thinking to myself, well, what are some of the questions that I get on a frequent basis? What are the questions that the frequently asked questions that I get? And since I only have 20 minutes, I decided, let me focus on some of these things, but also let me see how we can talk about effective, essential, everyday wound care. And so we're going to narrow this down, but then we're going to broaden it a little bit as well. So these are questions that I've gotten over the years that are very, very frequent. And I'm not trying to deter people from asking these questions, but they are questions that come up all the time. Does this wound need antibiotics? How would you treat this wound? Can we use a wound vac on this patient? And then a couple of my favorites, which is better, silver or honey? What's the difference in Vosh and Dakins? And my personal favorite, you guys can think about this for a second. How many of you ever thought, why are the clinicians who do wound care so weird? Any show of hands? I knew it. How about those of you that have actually come to me and asked me that in person? There are a few of you out there. I don't forget. So what we're going to talk about are a few things in terms of how we traditionally do things in wound care and how we approach wound care, but also how can we be more proactive, as Singh mentioned, even on the AI front, some things that could be done involving our teams, but also thinking more proactively. Appreciate the talk that David gave there on these learning models. There's so many of them out there. But let's think about what we do on a daily basis for how we approach wounds. And obviously, it starts out with our nursing team, the CNAs, the nurses, rounding on our patients, and they'll notify us when there's an issue, tell the primary care. We then get a referral. Sometimes we'll do some diagnostics. And then we treat the wound as it appears. And so this may force me to retire a little bit early, but is there a better way to think about wound care? Can we think about it before the wound actually develops? And yes, some of this is a little bit of a takeaway from the Norton score and the Braden scale and things like that, but how can we identify risks sooner? How can we intervene sooner? And how can we prevent progression once the wound develops? Because we know it's such a burden to the healthcare system, for one, but more importantly, the debility that occurs, the loss of function that occurs with those patients that see progression of wounds going from a simple wound or an area that's not blanching into something much more nefarious. So this pre-wound patient, if you will, has come up a lot of times today. That frail patient, that elderly patient that is there, and we all know them, of course. They have limited mobility, multiple comorbidities. These are our patients that we see on such a regular basis, we don't even think about it, right? But the fact is that you would think that with this vast number of patients we have, on average 100 patients per building, you would think that at some point over the course of several years, I would probably wind up seeing every single patient. That's not the case. It's usually only about 10 or 15% of the patients that actually develop a wound, and there's so many reasons as to why that happens. So let's start to think about, and once again, this is sort of not really a rip-off, but just kind of expanding upon what we know from the Norton scale and the Braden score and so forth. So Some things that are very important that I think that we look at on a daily basis on our patients, and it's not something that I see every day, but those nurses and the primary care folks that are out there may see more frequently than I do. You see mobility. You're looking at your patients and you're assessing, has there been a decline in mobility? Is there an increase in time in their bed, increase in time in their chair? Because what happens? These things lead directly to pressure injuries. And remember this, as movement decreases, pressure increases, right? So they kind of go hand in hand. So as you're noticing that your patients are declining in their mobility, they're staying in bed longer, staying in their chairs longer, there's more risk of a pressure injury developing. And I'm not asking you all to really memorize these things, but skin changes do occur, right? As we get older, there's a loss of elastic tissue or elastin in the skin. You lose hyaluronic acid. There's a decrease in number of fibroblasts, decrease in collagen. The skin becomes more translucent. You get thinning of the epidermis at the layer between the dermis and the epidermis. And the skin just becomes more fragile, right? So this is due to that flattening between those two layers. The skin winds up bruising a little bit more easily, and wrinkles develop. All these skin changes happen that we see obviously on the surface, but there's a lot more that could be happening beneath the surface that could drive a change that we need to intervene on. I bring up foot risk because it's one of the easy things that we can do, right? We can take a look at our diabetics, and I look at ABIs all the time. The diabetics and the smokers that we have, I know there are very few buildings that are still smoking buildings, but the diabetics who are smokers, they're at so much higher risk of developing PAD. Dr. Pallet and Dr. Patel, I don't know where she is, but we just did a presentation at AMDA on the risk of PAD and intervening in those patients, and obviously the loss of function that occurs when these things go untreated. But you can think about your neuropathic patients as well. Any nail issues, those things can develop into osteomyelitis as well, and then ill-fitting shoes. These are things that we need to look at, maybe not as us so much because we're not the ones that are looking at our patients on a daily basis, but encouraging our nurses, our nursing staff, our CNAs to do those things more frequently. So another thing that's a very big and important thing for me, is nutrition. We know that we need energy and protein to heal. And so the term that's come up so many times today is frailty, right? So somewhere along that frailty score, with more frailty, you have a poor healing capacity, right? So if you have protein deficiency or unintentional weight loss, these are things that are going to pop up on your EMR and should alert you that, hey, there's been a decline in condition here. There's a reason for that, because when those things happen once again, there's a greater chance that a wound is going to develop. And then, of course, another component of the Braden score and the Norton scale is incontinence, right? Moisture-associated skin damage can start out very innocently, and then the next thing you know, and I'm saying this very out loud because we have our friends here from CDPHE, moisture can lead to a pressure injury, right? So if we're not taking care of these patients and recognizing that there's been a change in condition or they're becoming more and more incontinent, that this could lead to more breakdown and then eventually lead to a pressure injury. So what's the pattern here? What's the pattern? In the patients that I've described, they don't necessarily have a wound. So why are we worrying about them? These are kind of like that pre-wound patient that I was talking about. All of them have the potential to lead to wounds. So I get asked, I go back to that initial slide of the FAQs, what would I actually use, right? And it's a question that comes up very frequently, and it's been coming up. I've been doing this for over 10 years now. I'll tell you a little story here for a second, and I'll embarrass our fearless leader over here, Dr. Pallet. I was rounding in a facility about 8 years ago, and I had just started rounding there, and everybody has known Dr. Pallet for a very long time. Singh has been an amazing presence in the community for a very long time, and I think I had just finished rounds, and I was walking out the door, and I heard my name, so I turned around, and there she was, and she said, "Excuse me, thank you, just want to introduce myself. Wanted to let you know we really appreciate what you're doing in here, but I had a question about a patient that's not here. Do you mind if I kind of curbside you on this patient?" Like, of course, this, and to myself, I'm thinking, wow, this is Singh Pallet here. She's actually asking me a question. So I was very flattered, of course, and just a show of hands, how many in here do wound care on a regular basis? Yeah, so think to yourself, when you get asked a question, and Singh asked me, she presented the patient to me and explained the wound and how it developed, and she asked me, so Raj, what would you do? Would you use silver gel, or would you use honey, or something else? Those of you that do wound care on a regular basis, you can agree with me on this. I'm sure 99 times out of 100, you go to the standard answer. Well, they're kind of interchangeable. You can, it just depends on your preference, which is pretty much 99% of the time I use that answer. But this was Singh Palette. And here she was once again asking me a question, and I was completely flattered. I thought, this is the one time I'm not going to go there. I'm gonna impress Singh so much. And so for the next, 10, 20 minutes or so, I started talking about the differences in the mechanism of action of silver gel and honey, the spectrum of activity between silver gel and honey, the gram-positive and the gram-negative. And I talked to her about MRSA and VRE and how one was more effective than others in Pseudomonas. And even looking at fungal activity and how silver gel can be a little bit more effective in it and how it can affect the biofilm. So poor Singh, she's just kind of staring at me, and we all know her, right? She just looks at you, and she's absolutely paying attention the entire time. We know that. Just nodding her head, like, oh, wow, that's very impressive. And so, but I couldn't stop there, right? I could not stop there. Once I got started, I just kept geeking out, right? So Vash wasn't around then, but then I started talking about Dakins, right? So Singh, if you asked this question today, I would probably include Vash in this. But Dakins versus Vash, big differences there. They're very similarly used, but there are some differences in there. So the mechanism of action, of course, hypochlorous acid versus sodium hypochlorite, the antimicrobial activity, antifungal activity, and what it does to the biofilm, and the tissue toxicity. And there's a little bit of a typo there. Dakins can actually sting. It shouldn't say cannot sting. But I get asked a lot, do you prefer Dakins? Do you prefer Vash? Do you prefer silver gel? Do you prefer honey? And once again, my standard answer is well, they're kind of interchangeable or so. And so after all of this, and once again, Singh was paying attention the entire time. I'm sure as she's watching me, she's regretting asking me this question. But then she just stopped and she said, wow, thank you so much for explaining that to me. But I have one more question. So silver gel or honey? And before I could even say anything, she said, I think you mean silver gel, right? And it was a very proud moment because she knew what I was thinking. And so it was a very, very proud moment for me. So, but the fact of the matter is you just need to keep it simple, right? There's so many products out there, and you just need consistency. And honestly, prevention is really the best treatment. If you can think about it in this way, what is the best wound that you treat? It's the one that never actually happens, right? So on our side, we try to be very proactive about it. We want to be more proactive in encouraging and educating our nurses to be very proactive about thinking about what actually we can do differently. Identifying things like edema, mobility, changes in those things, changes in things that you see every day, nutrition, skin. And the other thing, I talked about how weird we are, right? So if you've noticed, those that do wound care on a regular basis, everything goes back. Once again, we have lunch coming. Everything goes back to food, right? So whether it's the consistency of discharge, which it could be milky, we have odors that remind us of grapes. We have characteristics or quality of wound that reminds us of ground beef. Everything kind of goes back to food when we start describing things. And so on my end, I couldn't help myself. I came up with a mnemonic that we can use regularly just so you don't forget about it, right? So muffins, right? M is for mobility, F is for foot care, incontinence, nutrition, and skin changes, right? So this is just a really simple thing we can pass along to our nurses. Just think about muffins, right? When you think about wound care, think about muffins. But what can we do differently? We can look at our patients and we can look at, these are the most common places where you'll see wounds develop. If you take away the diabetics and the PAD and those things, these are really simple things. Just look at the heels. If I were to do a head to toe on a patient, where would I spend the most time? I would look at the heels, I would look at the sacrococcyx, and I would look at the right and left ischium. That's really where most wounds typically start. So what can we also do differently to get ahead of things if they do have edema? Compression, obviously, right? Get an ABI, make sure that they're compressible. Offloading, once again, the Braden and the Norton scale used for guidance. But if they do kind of range in the 18 or below range, you probably need to do something more and get more proactive about it so that you're actually staying in front of it. Because heaven forbid they do develop a wound and you noticed that the Braden was at a 17, well, they're at a 25% risk of developing a pressure injury. If they go down to just a 14, it's even higher. It's much higher, actually. Skin protection, of course. And then once again, one of my favorite things to talk about is nutrition. And, get the dietitian involved if you see not just a decrease in how much they're consuming, but you can also note muscle wasting. You can also note things like that just look different about the patient. Maybe that could even be leading to why they're not getting out of bed so frequently. And then build simple processes, right? So routine skin checks. I know we do those on a frequent basis, and that's certainly facility dependent. And then also flagging risk, taking a look at the Norton score and the Braden scale, reassessing when there's a change of condition, building staff awareness, of course, and driving that with team-based care, not just looking at it from hey, I'm going to go look at my patient today. I haven't seen them. This is my reg visit. Let me go take a look at these things. We're obviously not there enough to actually see those things as they change, but if we can empower our nurses and CNAs to do that, that is really what effective, essential wound care is on a daily basis. So finally, I'll go back to the initial question. Am I Team Silver? Am I Team Honey? Am I Team Vosh or am I Team Dakins? Honestly, they're really kind of interchangeable. I think I'm just Team Weird, so thank you all. That's all I have. Any questions? Yeah, happy to take questions.
Yeah, we got 5 minutes.
Any questions from anyone? I'm sorry, I can't hear you. Oh, like skin substitutes and so forth?
Yeah.
Or grafting? Yeah, I mean, we don't use them in our practice. I think there is a place for them in certain populations. I know the government has tightened down on a lot of the use of these products. I think it's a really good thing. There are select patients that do benefit from them. I've trialed them myself a few years ago, and they can be very effective. So he's asking about the use of expensive products in wound care. And frankly, there are many ways to treat wounds. Am I getting the right question, David? Yeah. There are a lot of ways to treat wounds. I personally feel like the use of skin substitutes is something that should be done at a higher level, not at the skilled nursing home level or the assisted living level. The home level, I think it should be used at a higher level in a hospital in an acute care setting. That's just my personal belief. I think the use of it on a patients in nursing home, there's too many variables, frankly, that you can't control in the nursing home environment. And that's not a knock against us. It's just those products are so expensive. I just don't feel like they should be used if you can't control the variables that are needed to be controlled for the use of skin substitutes. Another question in the back. Hope I answered your question there.
Thank you. Can you help please clarify or give me some guidance on how do I effectively pressure offload when someone has, say, a stage 3 or stage 4 heel ulcer, and also encourage mobility at the same time?
So this is where you want to involve your physical therapy folks as well. The loss of function obviously is a tremendous thing, right? As we're taking a look at these patients who just even not being able to utilize to be able to get out of bed, I think is tremendous, because you go a few days, they get so weak, they get so debilitated that even it takes several weeks, sometimes months to come back after they haven't been out of bed for a long time. So it is a bit of a catch-22, you're right. In terms of offloading, it's important to, our boots, the bunny boots, if you'll call them that, are certainly very effective. I think that's probably the place that I start the most frequently. But the balance is, you're absolutely right. It's a catch-22 because you don't want them to become so debilitated that they stop walking, they don't get out of bed anymore, they don't go to the commode. So I encourage the use of therapy. Toe touch, weight bearing when they have a heel wound is probably the best way to do it, but sometimes that's not safe. But that's maybe the only way, one, to heal the wound, prevent it from becoming a much more serious wound if it's a stage 3, stage 4, is to offload and try to limit the amount of mobility that they're doing. But you can obviously do exercises in bed, and that can be beneficial. And once again, therapy can be helpful in facilitating that. Any other questions? David?
So to culture or not to culture, to PCR or not to PCR?
Great questions. Certainly don't believe in pan-culturing patients. I think the culturing has to be done on a guided basis when you suspect something, especially in patients like diabetics. I mean, those are the ones that are, you're going to be suffering with their milieu, if you will, is going to be so different. They're higher susceptibility for wounds and for developing infections. Culture, you can use a lot of different methods for taking a culture. The gold standard is, to answer your other question, the gold standard for using culture or for determining if there's an infection wound is to do a culture, not PCR. I know we've talked about this with urine PCRs as well. The gold standard for a wound to determine if infection is there is to take a piece of tissue, send that into the lab, and determine what's the actual bacterial load in the wound, which a PCR cannot tell you, right? So if you're suspecting it, you can take a piece of healthy tissue, not unhealthy tissue. However, that's not always possible. You have patients that are on blood thinners. You have patients that you may not be able to do that safely in the nursing home environment. So you can use what we call the modified Levine technique. Betadine, I know Dr. Gam is in the back and he's helped me through this as well. Betadine very liberally, irrigate very, very liberally with saline, and then find the healthiest spot that you can within that wound. And if you have a lot of healthy spot, find the darkest spot in that wound, and then use the tip of the swab and allow some of the effluent to come back into the actual swab itself. Spin it for just a second, and that'll draw the bacteria and the effluent in there. You can send that off. Obviously, like I said, the gold standard for sure is culture, not PCR. But you can use the modified Levine technique to swab patients, but on a very directed basis, not on a broad, anybody that has an open wound, we're gonna swab. Absolutely not. Okay. Any other questions? Okay, thank you.
Yeah, that was wonderful. Thank you. And just a warning, Dr. Shepard, Dr. Reddy, Dr. Reitman, since you asked Dr. Raj a question, you are at risk of being in his next presentation, apparently. Yeah.